So now let us look at section 5, conditions associated with the viral origin. For this session, we are going to look at infections, viral infections of the skin, such as herpes simplex infection and the herpes zoster. And then we look at the collaborative management or treatment of these conditions. So at the end of the session, it's expected that the student will identify viral infections of the skin and their appendages, and then describe pathophysiology of these conditions. So we are looking at herpes simplex infection, we have the herpes zoster infection, and then treatment or management of skin conditions as well as the virus. So herpes simplex infection. Viruses usually depend on live cells for reproduction, and so are classified as intracellular pathogens. So the virus that cause skin lesions invade the keratinocytes, reproduce, and then either increase cellular growth or cause cellular death. And so an increase in the incidence of these viral conditions or disorders has been attributed to a number of causes. So some commonly used drugs such as corticosteroids, and then corticosteroids is known to have immunosuppressive properties that allow the viruses to multiply, and then other drugs such as antibiotics, as I've already told you, kill of normal skin bacteria that otherwise protect or defend against viral infection. So viral infections cause many different kinds of skin disorders. We have the simplex, we have the zoster. So let's look at herpes simplex virus, which is the HSV. So herpes simplex virus infection of the skin and the mucous membranes are caused by two types of viruses. And here we have the HSV1, which is the herpes simplex virus 1. So type 1 is found primarily on the face, lips, and then in the mouth, and is referred to as the fever blisters or cold sores. And it's also occasionally found in the eyes. And then we have the HSV2, which is the herpes simplex virus 2. And this type mainly associated with the genital tract infection are transmitted by sexual contact. So transmission of HSV is primarily skin to skin or skin to mucosa, and the incubation period may be somewhere from 2 to 20 days. So the virus usually may be contracted in early childhood, and is harbored in the dormant state by cells in the sensory nerve ganglia, and may be causing recurrent lesions. So reactivation of the virus can occur with fever or exposure to cold sores. And so the infection begins with a burning or tingling sensation, followed by the development of redness or erythema, and then small vesicles formation, and then pain may occur. And so what happens is that the vesicles pass through shallow abscess, and then crusting is likely to occur until healing occurs in 10 to 14 days. And so the infection, initial infection of the condition is often severe and accompanied by systemic manifestations. We can think about fever and then the sore throat. Now let's look at the herpes zoster. And then herpes zoster is a viral infection as well, caused by varicella zoster, the same virus that causes chicken pox. So the infection is believed to result from reactivation of a varicella virus remaining in the sensory dorsal ganglia after a childhood infection of the chicken pox. And so that is when after the case of chicken pox runs its course, it is believed that the organism responsible for the outbreak lie dormant inside the nerve ganglia, as I've already told you, near the brain and then the spinal cord. And so later, when these sleeping viruses become activated, they travel by way of the peripheral nerve to the surface of the skin. There, the viruses multiply by their numbers, and then create a red rash of small fluid-filled blisters. What I'm trying to tell you is that when somebody becomes immune compromised, for instance, have HIV or tuberculosis or any other condition that renders the patient or the person immune system lowered, then it's likely that that provides a conducive environment for reactivation of the organisms that are resting in the dorsal ganglia to come to the surface of the skin and then cause kind of condition. And what we are saying is that if you look at the way peripheral nerves are arranged, these organisms come straight through the nerves because already they are resting in the nerve areas. And so when there is a reactivation where the immune system is weakened and they are coming to the surface of the skin, so they come in a perpendicular manner, and so they never cross. And so that is why when somebody has herpes zoster, the lesions never cross. There is a saying that if the lesions cross, then the person will die. And that is never true. We look at the anatomy and physiology of the way the nerves are arranged. They don't meet, they are perpendicular. So when these roots are taken from their origin, and then the organism is traveling along this pathway to the surface of the skin, then they will never cross, unless probably certain changes occur, which we can't discuss now. So the virus becomes inactivated when the person's immune system is lowered, and there is increased frequency of herpes zoster in patients with weakened immune system, and the malignancies, especially the leukemias and then lymphomas. And this also occurs more commonly in older patients, and then because of natural decline in cellular immunity seen with normal aging. So it is more prevalent in people who are immunocompromised, such as those with HIV infection, I have told you already, and those who are receiving radiation therapy, and then people with chemotherapy. So the appearance of the lesions in people with HIV infections may be one of the first manifestations of the immune compromise. So if somebody has this kind of condition repeatedly, what happens is that we need to screen the person for HIV status. And again, patients with immunity lowered, for instance, tuberculosis and then diabetes and others, we need to screen them when they have this kind of a condition. But herpes zoster is far less communicable than chickenpox. So persons who have not had chickenpox may develop herpes zoster after exposure to the vascular lesions of a person with it. So for this reason, susceptible persons at risk of getting the condition, example, with lowered immunity, should not care for a patient with the herpes zoster, and so those people can get it. So the lesions usually appear on the face, the trunk, and then the thorax, especially those around the thorax. They said that when it goes around, then the person will die. Once it's not like that, but the point is that, as I've already noted, patients or people with cancers, leukemia, are likely to have this. And then the primary condition, which is the cancer, especially the leukemia or cancer of any other parts of the body. We know cancer can kill people at any point in time, and it's associated with immune systems. What happens is that the person is rather going off as a result of the primary condition and not the secondary condition. That is why they say that when it crosses the midline, then the person will die. It's not rather the zoster which is killing, but the primary condition which has rendered the person's immune system lowered. So in herpes zoster, a cluster of vascular lesions are arranged in linear fashion, and so they follow the course of the peripheral sensory nerves, and hence the lesions never cross the midline of the body. You have to know that to be able to do meaningful education in the community. So if lesions do cross the midline or become generalized, the patient may be having a possible or primary malignancy, and that is maybe the cause of the death. So they are often unilateral, but nerve groups on both sides of the body can be involved. So through tests of persons with herpes zoster develop lesions over thoracic dermatomes, and then the remainder show involvement of the trigeminal nerve with lesions on the face, eyes, and then the scalp. And so that is exactly what happens. We can have a lot of clinical manifestations, and then we have the configuration, as I've already told you, and it's very discomfort, can cause pain, and in most cases the disease is benign and localized, and the complications include post-hepatic neuralgia, a sharp spasmodic pain along the course of one or more of the nerves that are involved, or it can also lead to visual loss. And then the neuralgia described as burning or stabbing manifestation that results from inflammation of the root ganglia, and this complication occurs in about 50% of patients over the age of 60, and then permanent loss of vision may also follow the lesions that arise from the ophthalmic division of the trigeminal nerve. So the disease may disseminate in immunocompromised patients or clients, and then causing lesions in the dermatome, which may include visceral lesions, and then complications may include death. Of course, every condition, then the ultimate is death, so it may not be a complication. Okay, so diagnosis based on manifestation and the appearance of the lesion. Laboratory investigations, we can do zinc smear test that identifies the herpes virus, and it is a microscopic examination of the cells from the base of the lesions, and this can be done through scraping. So we are looking at the lab and the diagnostic tests. We have the zinc smear, which may be done as looking at the base of the lesions, and then take some cells for examination, and then culture of fluids from the vesicles. Now, if I say vesicles, you understand, and these are also used to make the differential diagnosis of herpes types, and then other management. Collaborative management centers on pain relief of the pruritus, decrease severity, and then length of the illness, prevent infection, and then scarring, and then reduce the possibility of post-hepatic neuralgia. So the treatment are centers on this. So herpes simplex lesions are treated with aciclovir and then other medications, which later you can take your time. We have different commercial types which you can use to treat, and then some of them have advantages over others, and then for some of them they can treat both the pains and then the neuralgia associated with the post-hepatic manifestations, and then others are just limited to the analgesic properties, whereby they can treat only the pains, but some of them are potent more than others, and then some are very strong as compared to others, and then local discomfort may be relieved by topical antipyretic agents such as the gels. We have the Prax and then the Pramagel, and then we have the aluminium acetate. They have different commercial names. These are applied as cool complex and may provide local relief and then quicken drying of the vesicles. And then corticosteroids may also be used to decrease the inflammation or inflammatory responses, and have been effective in some cases, but their use is controversial because they also decrease healing and then suppress the immune system. And the antihistamine may also be administered to relieve pruritus, and clients with eye involvement are also treated with topical steroid ophthalmic preparations. Pain, we have to look at that. In terms of nursing, we have to look at pain issues, and then we have to ask the patient to be able to describe the type of pain, and then so that we can give appropriate treatment, and then assess and monitor the location, duration, and then intensity of the pain is also important, and then administer the drugs as prescribed by the doctor, and then use measures to relieve pruritus. We have to prescribe antipyretic medications, and then in some cases the commonest drug that we can use is calamine lotion if prescribed. Keep the room temperature cool, and then may also be used in cases where it's very severe, cradle, to keep heats off affected areas of the body. And cradle, we can use it especially in children, and then encourage the use of distractions such as music or even watching TV. In most cases, especially in children, we need to contain them to be able to avoid, to stop scratching the area. So in some cases, we can use gentle tying of the arm and then cover the nails so that they cannot scratch the affected areas. We need to control and then also look at the sleeping patterns, and then provide appropriate interventions to relieve pain and then pruritus. That can also improve their sleeping patterns. And the risk of infection, clients with herpes zoster have impaired skin integrity, so we need to educate them on that and then monitor them in terms of medication and the rest. As part of nursing care, we have already looked at the effects of anxiety, so the presence of lesions and pain, and then we also need to look at that. And then self-care deficits, we need to educate them based on their knowledge that they have. Before we can do meaningful education, we need to assess what they know before we can do major planning. Again, before we can do meaningful education, we have to assess their understanding, or we have to assess their concept of the condition, whether they have any MIPS. Because I remember in some cases when you interact with patients, what they say is that herpes zoster, when you have this condition, probably you have met a ghost, and that's why you have the condition. And so these are all myths. These are not important things, that they are inappropriate, what do you call it, knowledge that the patients have. So you have to assess all these things, and then out of that, then you can plan type of education which can also help them to understand your condition. And then also, when it crosses the midline, the person will die. You have to, if the patient has such ideas, then you have to do proper education in order to organize them in a way that can help them to cooperate with you in the treatment and then the follow-ups. So we come to the end of the session 5. Thank you very much.